students. Welcome to a new topic of juvenile dermatomyositis. I am Dr. Sami Bhatia, and I'm going to take you through these very interesting topics which are very relevant for your exams. So let's begin. So what's juvenile dermatomyositis, right? It is the autoimmune disease which I say genuinely could not decide what it wanted to be. Like when it grew up. Whether it wanted to be a skin disease, sure, it announces itself by giving us a rash, right? Is it a muscle disease? Why not? There is proximal muscle weakness. Or it is a blood vessel disease as there is inflammation. Absolutely. It's all three, right? And hence the name dermatomyositis. Dermato, which means the skin, myo means the muscle, itis means the inflammation. And why juvenile? Because it shows up in childhood, right? So the name juvenile dermatomyositis. So what actually is juvenile dermatomyositis? First of all, it is the commonest inflammatory myopathy of childhood, and at its core, it is a systemic small vessel vasculopathy, which in plain English means a disease of tiny blood vessels that just happens to scream through the skin and the muscle, right? So we need to picture three jobs that the skin wears it. That's the shop window where all the rashes live. The muscles feel it. It's symmetrical proximal weakness, right? And the vessels cause it, which we said is the engine room. So it's a vessel disease that shouts through the muscle and the skin. So we need to treat this inflammation and the rest tends to follow. The numbers examiners love to fish. Incidence, right? So the incidence is roughly 2 to 4 cases per million children every year, which is rare. You will not trip over these on every ward round. The peak age of onset is around 4 to 10 years, averaging around 6 to 7, and the sex ratio is around 2 is to 1. It is female predominant, as with most of the connective tissue disorders, and importantly, approximately 20% of the all dermatomyositis cases have a juvenile onset, so majority is still an adult onset disease. So why does it happen? Picture a two-hit setup, guys. Hit one is the host, right? A genetically susceptible child with certain HLA types, a few interferon and cytokine quirks. Hit two is the trigger, an infection, sunlight like a strong UV light, or maybe a drug in a wrong person. Put a susceptible host together with a wrong trigger, and the immune system files a friendly fire report against its own blood vessel. For the trigger, just remember the three B's: bugs, beams, and bad drugs, which is like infection, UV light, and drugs. Now, let's follow the vessels because this is where the marks are hiding, right? As we have discussed till now. So, step one is the antibody and complement. That usual pathology which we used to read in pathology, the membrane attack complex. The C5b9, it gets dumped into the lining of the small vessels, which leads to the step two. When these membrane complex deposit into the endothelium, this causes us endothelial injury, which injures the capillaries, and there are microinfarctions now which develop within the muscles, right? With fewer capillaries, the muscles become further ischemic, and the fibers which you see on the top right of the slide, the fibers further from the blood supply suffer the most. And as a result of all this is the pathognomic finding of the juvenile dermatomyositis is the perifascicular atrophy. That is, the muscle fibers at the very edge of each fascicle wither away because they were last in the queue for blood. You just have to burn this in. Perifascicular atrophy is the hallmark of dermatomyositis. So, just to summarize, a child with a rash, shrunken fibers at the rim of the fascicle, the answer is dermatomyositis. And notice that it's the complement attacking the vessels. rather than polymyositis, where we see that the T cells attack the muscle fibers directly. The other pathophysiology which we have recently discovered is the interferon. And that's the reason why in today's era there is a role of JAK inhibitors, right? So we have seen that when there is a virus inside a body, the plasmacytoid dendritic cells, which are known as PDCs, they sense the viruses via toll-like receptors. This causes a surge of type 1 interferon alpha and beta release from these cells. This interferon release drives the MHC class 1 into the muscle fibers, which become abnormal, and this is hence one of the earliest changes. The MHC1 overload stresses the endoplasmic reticulum, which degrades the contractile protein, which further weakens the fibers. That's why, and this type 1 interferon signals via the JAK-STAT pathway. That's why these days there is a role of JAK inhibitors, which can just shut off this switch. The some to name the drugs are tofacitinib, which is a very recent drug which are emerging, and hence we'll discuss the MDA5, what are these, but these are the emerging in refractory and MDA5 and ILD disease. Other biomarkers which are recently being discovered are the galectin-9 and the CXCL10, which are interferon-driven proteins validated as biomarkers of JDM activity. Now let's come to the clinical features. First, the rashes. These are the ones that practically diagnose themselves. Gottron papules. These are violet scary bumps sitting right on the knuckles, elbows, and knees. These are pathognomic, which is a fancy way of saying if you see them, you're basically done. You have got the diagnosis. The other is a heliotropic rash, a dusky violet stain across the upper eyelid, sometimes with a puffy swollen look. Then are the non-specific ones, which is the shawl sign and the V sign, which is nothing but sun-exposed redness draped over the shoulders, upper back, and the front of the chest. Then other changes which are seen are the nail fold changes, like dilated dropping out, corkscrew capillaries right at the cuticle, which is vasculopathy, and it's not a microscopic finding, it's even visible to the naked eye. Other features being mechanic hand, which we say is cracked, rough fingertips, and even in more severe or undertreated diseases, there's quite a lot of calcium deposits like calcinosis and skin ulcers. Other very important thing is the facial erythema of the JDM versus the SLE. Whatever facial changes occur in the form of rash, they cross the nasolabial folds, while in the SLE, the characteristic malar rash, which is seen in the SLE, spares them. The muscle story is all about the pattern, guys. So weakness, which is symmetrical and proximal, that is, it's the involvement of big muscles close to the trunk. So the child struggles to climb stairs, which we say the Gover signs, to get up off the floor. And also there is proximal hand weakness also, so they are unable to comb their hair. But as seen here, the reflexes are preserved and the sensation is intact because this is a muscle problem, not a nerve problem. The other features beyond the muscle are the very dangerous signs, which can be due to gut vasculopathy and can lead to an abdominal pain. Usually, when the gut vasculopathy starts and you get abdominal pain in a child with a diagnosis of juvenile dermatomyositis, it is a poor prognosis sign. Other being trouble swallowing, which means aspiration risk, lung disease. The lung disease, guys, is associated with the MDA5 antibody, and this antibody, please remember this for your exam, that this antibody is characteristically associated with the lung disease. And also a very unique feature of lung disease is that for juvenile dermatomyositis, it's the hypercarbia, not the hypoxemia, which brings the child, right? So there won't be any increase of work of breathing because there's no hypoxemia. So there'll be very few distress signs. So if you're waiting for the increased work of breathing, then it might be very late before you pick it up because it's a hypercarbia which will bring the child to you, not the increased work of breathing. So hence you have to do periodical test by doing vital capacity, which is the lung function test, just to know. what the lung involvement is. It can also involve the heart, like myocarditis, conduction disease, but is very uncommon. Joint, again, non-erosive arthritis, but again very uncommon, and they can be constitutional features like fever and fatigue. Remember, PP, proximal muscles, preserve reflexes. The two P's keep JDM weakness apart from a neuropathy where reflexes vanish, right? Yeah. So how do we make the diagnosis? So the characteristic diagnostic criteria which was earlier used was Bohan and Peter criteria. It can be still tested in your exams. It was given in 1975. The diagnosis on this criteria is based upon the characteristic rash which we have discussed, plus three of the four features which we can name as WEEB, the mnemonic WEEB, weakness, enzyme, CMG changes, and biopsy. Weakness we discussed is a symmetrical proximal weakness. The enzymes can be elevated, the CK, AST, LDH, aldolase. They can be characteristic myopathic changes on the EMG. The biopsy can show necrosis, inflammation, plus perivascular atrophy. Again, they are quite patchy changes. Hence, even if you do invasive tests, if you do it from the normal part of the muscle, you might miss the diagnosis. Hence, in today's era, invasive tests like EMG and biopsy are rarely used. Some places do use it where diagnosis is very uncertain, but modern practice has actually substituted these tests with like my MRI, which can show you inflammation with and myositis specific antibodies, which you can do from the blood. Then there is another entity which is called the amyopathic juvenile dermatomyositis. As the term suggests, it means skin without the myositis, right? So there's rash but no weakness. So there will be the classic Gottron and heliotropic rash, but there won't be any muscle weakness and hence normal enzymes, right? So it can also be called DM sign myositis. So it may be very hard to pick. However, MRI may show muscle edema sometimes, or positive myositis specific antibodies can be seen in the blood, but again, very rare. Why it matters in today's era is because skin limited diseases, even though it is without muscle involvement, can still progress to have severe complications such as calcinosis. So it does warrant treatment, and you should just not say that the muscle is not involved, so we should just not treat it. It also has to be treated. So if a persistent ulcerating rash, nail fold capillary dropout, or a positive antibodies, all push towards active treatment, right? So it's not merely a cosmetic disease. So investigations. So muscle enzymes, first of all, the AST is elevated in majority. Some people do say that you can also, the LDH is elevated and it's one of the markers that you can use to track the activity of the disease. Like with the disease flaring up again, the LDH might rise again. The other things you can follow, enzymes you can follow are the CK and the aldolase, but be mindful CK can be normal. So a normal CK should never rule out juvenile dermatomyositis. The autoantibodies, the ANA, again, non-specific, can be positive in greater than 80% of the cases. Most important is the myositis-specific antibodies, which we are just going to see through. And if you believe me, then this is the most important slide, which will come next. Again, a very important exam question. The ESR will be often normal. The RF typically negative, which hence these are the classic negatives, which you might think with the connective tissue may be positive. The MRI will show symmetric hyperintense edema in proximal muscle. Again, patchy, but MRI will do the whole muscle, so you can always see. And in case that where there is diagnosis is doubtful, it can guide you to the biopsy site as to where to take the biopsy. The typical sequence we use are the T2 fat stat and the stir sequences. The muscle biopsy remains still the gold standard, but very rarely used in today's era. If you do a muscle biopsy, then there will be perivascular fascicular atrophy, as we discussed, the perivascular inflammation, capillary loss, the gold standard, right? Then some people do nail fold capillaroscopy to see the dropout, dilated and tortuous loop, but again, it's not definite diagnostic criteria, so more for pathology basis rather than diagnosis. EMG again invasive. You might just do the EMG of a normal part of the muscle, so and you may miss the diagnosis. Hence, it is now often skipped in favor of MRI plus autoantibodies. Now, this is the most important slide, the myositis-specific antibodies, and each one has its own personality. And the antibody often predicts the phenotype better than the muscle does. That's the whole reason we serotype. The first one is the anti-TIF1 gamma. It often points to the stubborn skin disease. So just remember TIF the skin, right? TIF the skin. Just say to yourself 5 times, TIF the skin, TIF the skin. The other is the anti-NXP2 antibodies, which is associated with calcinosis. And as I said, calcinosis is a late complication, so it's a marker of severe disease. So you can say NXP the stones, right? TIF the skin, NXP the stones. Then is the anti-MDA5, which is again is very important association with interstitial lung disease and also ulcerative skin. And it's the one, if one antibody has to be seen in amyopathic juvenile dermatomyositis, then this is the one that's seen in the amyopathic variant. But if for the exam purpose, just remember anti-MDA5 is associated with the lungs. Then if you had to choose one among them that you want to have juvenile dermatomyositis but a mild variant, then it is the anti-MI2. So with the name you say MI, the first two word means mild, so MI2 plays nice, right? So MI2 means mild. It's the classics, just involves the skin and has a good prognosis. Then the other ones are the anti-Jo1, which is associated with ulcerations in the hand, which we said earlier was the mechanic hand. The other is you can remember is why the Joe does the manual labor, right? Then is the anti-SRP. You can name it as SRP means seriously rotten power. So it is the one which causes severe necrotizing myopathy, right? So TIF, the skin, NXP, the stones, MDA, the lungs, ME is the mild, Joe does the manual labor, and SRP means severe rotten power, which means severe necrotizing myopathy. Now let's come to the management, guys. The treatment, right? The backbone that almost every patient gets is again steroid. This is the backbone, right? The pulse of intravenous methylprednisolone, 30 micrograms per kilo per day into 3 days, and then oral prednisolone for 2 weeks, and then taper about depending upon the response. There's also the role of steroid sparing DMRDs, which is methotrexate, which is given once weekly, but is an injection and has to be given with folic acid. You have to continue 12 months after the steroid stop and the disease is quite. The adjuncts being IVIG, hydrochloroquine, sunscreen, physiotherapy, calcium, vitamin D, and you have to also monitor the bone and the growth monitoring. If you are having taking steroids or are on immunosuppressed drugs, then you, being a doctor, you need to tell the parents to avoid taking live vaccines. If you require the influenza one, take the inactivated influenza vaccine. And when do you step up, right? So you've given him steroids, given him methotrexate, but still the disease hasn't regressed, and now the child is having dysphagia, absent gag reflex. The weakness has become more profound. There are extensive ulcerative skin disease, or if there is interstitial lung disease. Then comes the role of other heavy options, which are IV cyclophosphamide, which is for organ-threatening diseases, rituximab, the JAK inhibitors, which we discussed, and these have taken a more important in MDA5 or ILD phenotypes. The other one is the rare experimental options, which are being researched upon, which is the HSCT and the CART therapy. So, what are the complications in long-term complications? So, we have to remember our calcinosis, which is calcium deposits in the skin, subcutaneous tissue, and the muscle. The calcinosis, as I said, NXP2, the stones, so it is associated with anti-NXP2 antibodies. And if there is late treatment or under treatment, then calcinosis is usually seen. Then there can be lipodystrophy, which is loss of subcutaneous fat, which can be secondary to other metabolic consequences also, and hirsutism, which can be secondary to the disease as well as to the steroids also. The other important thing is the malignancy. So the malignancy, though seen adult dermatomyositis, demands for a hunting of the occult cancer. Juvenile DM is not usually associated with the cancer. Now, prognosis and the disease course, that's how the story ends, right? So, in the pre steroid rule era, there was the rule of thirds, like one third died, one third remitted, and one third had carried the disease chronically. With the steroids and the immunomodulation, we have just rewritten the ending and see the staggering numbers that now there is less than 2% mortality in the modern era. The disease course we can say is can be monocyclic, where there is one episode and just remits within 2 years. Chronic continuous, that the it's continuing beyond 2 years despite treatment, and polycyclic is remits then relapses, and the worst one is the ulcerative, which has a very poor prognosis. Just to now summarize what we have studied, the environmental triggers are the bug beams and the bad drugs, right? Remember the it's a proximal is a proximal myopathy. Remember PP involves the proximal muscles, but the reflexes are preserved. Then the Bohan-Pita criteria is rash plus the three of the weeb being weakness, enzymes, EMG biopsy. Then remember TIF the skin, NXP stones, MDA the lungs. Then remember MI2. MI means mild, the first two letters of mild, so it plays Niles. And anti-MI2 predicts the good prognosis subset. Then remember the complication is CLH, but no no cancer, right? So calcinosis, lipodystrophy, and hirsutism, but very rarely there will be any malignancy. So if I have to recap in 30 seconds, it's the commonest inflammatory myopathy of childhood, a systemic small vessel vasculopathy. The two-hit hypothesis works for this. There is capillary loss which leads to fascicular atrophy. Remember the rash plus the three of the weeb. Steroids plus methotrexate acts as a drug. You have to watch for severe disease, which means absence of gag reflex, involvement of lungs like interstitial lung disease, ulcers coming. Remember the rule of third, like in the pre-steroid era. Now there is less than 2% mortality, and unlike adults, there is no malignancy. Hope you liked my lecture. Thank you. Until next time.